Ladies and gentlemen, welcome to today's engaging podcast where we will delve into the vital topic of melanoma. Joining us for this insightful discussion is the highly experienced dermatologist Dr. Samaa Shendy, who practices at the renowned Nile Skin Medical Center in Dubai, bringing 6 years of expertise in aesthetics and dermatology to our conversation today. So prepare to expand your knowledge on melanoma with the expertise of Dr. Samaa as she shares her insights and experiences. Welcome, Dr. Samaa. Thank you so much for joining us today.
Thanks to you. Thank you.
So we will be covering melanoma on diagnosis and treatment, and in terms of prevention and awareness, and lastly on melanoma equity and access to care. So, before further delay, let's begin our podcast. Now, to begin with, early diagnosis is very important in treating melanoma. Now, what are the latest methods for diagnosing melanoma and how can doctors effectively utilize them?
Okay, actually, let me just give a brief about melanoma. Melanoma is like a tumor or malignancy in the melanocyte, the cells that actually produce melanin in our body. So when there is multiple proliferation of these cells, it will actually cause melanoma. For the diagnosis, mostly 50% of the patients, they will diagnose themselves. You will find the patient coming to your clinic, they say, I have this mole or I have this lesion that have been there for a while and it is not it's not something that they are used to. After this, we will start to do the clinical examination. Lately, actually, we contributed the dermatoscope in the clinical examination of the melanoma that is giving the higher accuracy of the diagnosis. Then, mostly, we will ask the patient to do a biopsy to actually make sure this is a melanoma or not. But in the late 20 years or something, there have been different diagnostic methods that we have been trying to contribute in the diagnosis of melanoma to make early detection of the disease. For example, now there is a teledermatoscopy that actually the patient, there will be a correlation between the patient, a GP and a dermatologist. What will be like a series of photographs taken for the patient, and then the GP will send them to the dermatologist so we can make the diagnosis of the melanoma. And actually, this is something for the prevention of the disease. The third thing, there is something called computed diagnosis of pigmented lesions. It is not that much used nowadays because actually it's for all the lesions of the skin, not just melanoma, and it tends to overdiagnose the disease. So mostly for the diagnosis of the melanoma, now it's a clinical examination, dermatoscope, and a biopsy.
Now, talking about the melanoma treatment options, melanoma treatments have seen significant advancements. Could you give us an overview of the current options available along with their potential side effects, if there are any?
So mostly the treatment of the melanoma, it depends on the category or the subtype of the melanoma, the stage of the disease itself. So for example, the stage 1 or the early stages of melanoma, we will go immediately to surgical excision, where we do something called radical wide excision of the melanoma, where we will remove the lesion and a safety margin around it. It will be from 0.5 to 2 centimeters. It depends on the thickness of the lesion. Then we can go a little further with the central lymph node dissection when there will be a risk of metastasis of the disease to the lymph node. For the late stages of the disease, actually, there are so many treatments that have been profitable for the life assurance for the patient. For example, we have now the immunotherapy. We have the molecular targeted therapy, which was like a revolutionary treatment for the disease itself. For example, we have the molecular targeted therapy. We have two genes, or the main two genes that we have, the BRAF gene and the TIPK gene. The BRAF gene is actually responsible for 50% of the cases of the melanoma, And what happened now that we have found a treatment that actually can increase the life efficiency of the patients and shrink the disease itself by 50 to 80%. The SITK gene mutation also, we have found it that it can actually be targeted also with some treatment that can be make the treatment more efficient to the patient. We have the chemotherapy. It's actually one of the main treatments that is for the metastasis from the melanoma itself, and also, of course, with the interference, which is FDA approved treatment for the melanoma.
Now, prevention is key when it comes to melanoma. As doctors, what are the key sun safety recommendations we should be sharing with our patients?
Actually, when I'm telling my patients about the prevention, I am telling them stay away from the sun. This is the key. So some patients will say, no, I love the sun, I need to go to the beach and stuff like this. So mostly sunscreen is essential. Wearing hats and glasses, trying to avoid the sun as much as possible between 10 to 4 p.m. Also, of course, the sun protection of babies that are older than 6 months. This is the main thing. Also, for the prevention of the melanoma, it's not like a prevention, it's like for early detection. I am telling my patients, know your body. Like, for example, for people who have fair skin and they have multiple nevus in their skin, I am telling them, follow up with your nevus. Like, check your body regularly, at least every 6 months. And there's actually when patients are doing the regular checkup, they need to do skin checkup also. This is the main thing for prevention.
Now, moving on to our next topic on recognizing the melanoma signs, what are the specific characteristics or red flags in moles that should prompt the doctors to consider melanoma as a diagnosis?
Actually, we have something like algorithms called the AECDD. This is the asymmetry, like half of the nevus is different than the other half. We have irregular borders. We have different color changes. We have evolving, something that changed like very rapidly, difference from the other moles in our skin. Also, for people who have, like, for example, more than 40 or 50 nevus in their skin, we will ask them to notice if there is a different one. This is not the same pattern as their other nevus on their skin. So it's called the ugly duckling. The patient should know it. Also, if the patient there is a typical melanoma, if the patient have like an ulcer or sore that keep bleeding and is not healing properly, this can actually be a typical melanoma.
Now, genetic profiling is changing the landscape of melanoma treatment. In practical terms, how does it impact your approach, and what should doctors be aware of?
For the genetic profiling, it's more according, like, with the treatment. It goes with the treatment. So as I told you before, the BRAF genes, the CTK genes, the NRAs, this is the gene that we can screen for it according, so we can make our treatment according to it. But we have it's like a phenotype. For this is like, we will have, okay, this is a red flag for me. This person can be highly susceptible for melanoma. For example, this really fair skin people who have lots of time on the beach all the time, people who have a family history of melanoma, or a person who got melanoma before and they are susceptible more for recurrence.
Telemedicine is transforming healthcare. With the rise of remote consultations, how can doctors effectively conduct melanoma screenings? Actually,
these methods have been for the last 20 years. There is a company called Teleskin that they have something called teledermatoscope, as I told before. There is a sequence between the patient who go to the GP, and then they take the photographs, and then they send it to the dermatologist or the dermatoscopist. Okay, so this is how the patient. This is like a method of early screening for the disease itself. It actually helps with the accuracy of 72 to 92% improvement in the diagnosis and the early detections of melanoma. This is really important in the screening.
Now, moving on to our final question for today. How can doctors ensure fair access to care for everyone, considering potential disparities?
The doctor has actually what does it say? They have responsibility to actually educate the patient first, and then they will have to tell the patient that about the different types of melanoma, because melanoma can be so much like different in different people. So some people, for example, the superficial melanoma is something that all the doctors know, but if there is a typical melanoma, even the best of the doctors will fight about how, if this is the diagnosis, if this is the right diagnosis or not. To ensure a good care for the patient needs to be educated first. I should know which types of melanoma is more predominant in different age or different groups of people, and then according to this we will have to go with the treatment plans, because as you know, the superficial melanoma, it has a very high treatment rate, and the nodular melanoma is one of the worst prognosis in the melanoma.
Dr. Samaa, we extend our heartfelt appreciation for your invaluable insights today and for sharing your expertise on melanoma and for being part on dedicating to advancing medical knowledge on our platform. Thank you so much.
Thank you.
We're looking forward to many more podcasts together.
Inshallah.
Inshallah. And to all our dedicated listeners, if you found this episode enlightening and wish to stay informed about the latest medical discussions led by our esteemed experts, we encourage you to like, subscribe, and register on our MedSynapse website. Thank you. That's all for today. Until next time. Goodbye.